We have some dignitaries with us here this evening, and I wanted to do a few introductions. Where's Dave? Did he just step out? Dave Ballenberger? There he is. There he is in the front row. Dave, if you just wanted to stand up and wave, he is the president of State NAMI. And we have Dr. Tim Florence and Trish Cortez, who together run all of the CSTS services in this town. And this is their new waiting room. We've transformed it for our event this evening, and we'll transform it back. But we will probably be the last group to ever get to be in this conference room for a meeting. So we want to dedicate it well and clean up after ourselves afterwards. And there are a number of board members here from NAMI Washtenaw. So if you just all wanted to stand up and wave. Most of us have our new name tags so you can see who we are if you have questions. We appreciate all of your attendance. We hope this will be of benefit to you this evening. The topic is mental health matters, integrated medicine, taking care of your mind as well as your body, and hopefully taking care of them together. You'll get quite an introduction to integrated care by our panel. But I had a conversation with Trish and Tim earlier, and they were saying, you know, when we can't get mental health services in the place where you get your body taken care of, we just bring the nurses into the mental health care treatment and integrate it that way. So I'm sure that when we get to the question and answer portion of the event this evening, that there'll be a lot of, I'm hoping there'll be a lot of lively discussion. So our first speaker will be Danielle Ten-Cape Cole. And Danielle is a clinical social worker with the University of Michigan at Briarwood. And she really was involved in integrated care in St. Paul, Minnesota. And apparently they are ahead of where we are here in terms of what they're able to do. So I think that will be a very interesting discussion. We have two physicians with us, one from University of Michigan and one from Packard Health Clinic, who are going to introduce themselves and tell you a little bit about their practices and what they believe we could be doing to integrate health care. So we have Dr. Ray Ryan, excuse me, and Dr. Phil Zaza. And then it's my great pleasure, because she's somebody whom I have admired for a long, long time and supported when she ran for office, and just believe that she will be awesome, and I appreciate you being here. The Honorable Lynn Rivers, and she will moderate our panel. She'll keep us under control if the discussion gets really lively. And I just welcome you and thank you very much. And Lynn also reminded me when we were talking earlier that she's a consumer of mental health services, and so it's a special pleasure that she's willing to spend her time with us this evening. So with that, I'm going to turn it over to Danielle, and then you can turn it over to Lynn and the docs, and we'll take it away.
Wonderful. Well, thank you. I really appreciate the opportunity to be here tonight, and the group, what a great group. I don't know, maybe you picked up, I prepared just a really, sometimes having something written to look at helps a little bit when we're doing this whole thing of creating a definition or some common language around what we're talking about. And so that's what that handout that was out there was that I put together. But just to really kind of set the stage for the conversation, what is integrated health? What are we trying to do when we say that? What is this taking care of our body and minds in the same time, the same place really mean? And that's really the main point of integrated health, is let's bring our primary care and our behavioral mental health care into one place. Let's get everyone reading from the same care plan, the same health records, the same treatment plans, the same billing, so that everyone sort of understands and knows is working the same system together. And so, you know, we can get into all the different core principles, but you can just look at the handout a little bit about that. I think the question is why? Why do we do this? I think working in a primary care clinic, and people come into their primary care doctors for, well, I mean, I think what I go in for my primary visits for almost anything. And it's your first line when you don't know what to do, when you don't know who to call, you go to your primary care doctor. That's where people go. So, you know, whether it's diabetes or heart disease or a cold or an infection, but depression and anxiety, that's the first line treatment for most people for their mental health care as they go to their primary care doctors. And, you know, a lot of the studies and the research are showing that primary care docs maybe have been given some of the skills to do the assessment and maybe first line therapy or treatment for that. But beyond that, the resources for supporting them and providing care to their patients are pretty limited. And so the question becomes, how do we integrate better to get the patients the care they need, whether it be bringing mental health care into a primary care clinic or bringing primary care out to a mental health site. And it's also about taking care of the patients in a way that empowers them to get their care needs met in a comfortable and in a way that makes sense for them. So it's about access. It's about improving quality of life. So that's, and then I think there was an allusion. I came from Minnesota. I've been in the state of Michigan for about 6 months. I grew up in Michigan, so this is coming home for me. But we've been in Minnesota for about 10 years. And there's a lot of, and I don't want to say they're way far ahead of us. I think that the conversation is always about an evolving relationship around this. Minnesota, in general, is a fairly politically progressive state, I will say, as a social worker. And so I think that they maybe started some of this work in a different place, partly because of funding. I mean, I think of Medicaid funding and how Medicaid pays for services, and in Minnesota they pay higher for Medicaid funding. They pay providers more with Medicaid funding than what we see here in Michigan. And so some of like the Diamond study and the ICSI, the clinical improvement studies, have been a lot of those have been done in Michigan. But I'll say that there are a lot of really notable programs going on around the country, doing research, doing this kind of work. Washington is fairly well known for some of this. So Kaiser is doing some work in California and Colorado. And you can look at the list. I actually think there's even a small group out in West Michigan that's starting to do some work around this. And the idea also being about if we can create some evidence-based practice around this, then there's better funding for it. So the other thing that Bob had suggested that maybe I put together is maybe a couple patient examples, although I think that will be something that I don't know if you want me to do that now or if we should.
Yeah, why don't you go ahead and give it everything you have.
Sure. So, you know, just thinking even through the course of my week, it was pretty easy to think of a couple of really quick examples of for example, last week a nurse, we do a lot of instant messaging back and forth across the building because the nurse is on the phone with a patient who's calling in and saying, or a family member who's calling in and saying, you know, our family member's ready for treatment. Today's the day. What do we do? Where do we go? And then, you know, an instant message back, you know, well, you know, here are 3 or 4 phone numbers and they're going to want to follow these steps. And then today getting the phone call back, or getting the paperwork back actually from the rehab, or the rehab program, and the primary care doctor coming in and saying, okay, here's the care plan and this doesn't make sense to me and I don't know what next steps to take. And being able to get on the phone with the patient and create next step planning to get their medications managed for addiction, for mental health, the whole package deal, and taking next steps for therapy. And so that's one kind of care coordination example of how this goes. I will also say that a patient I saw this week with diabetes, fairly new diagnosis of diabetes, but having a really hard time managing it because anxiety is a big issue for him, and having trouble controlling his blood sugars and understanding his care plan because he's very anxious. And he's met with a dietitian and is having trouble following those plans because food calms him down. Food's a big part of how he manages his anxiety. And so he came in to see me around that, but also then having blood sugars go up and down and ending up in the emergency room because of that. So working with the dietitian, working with the nutritionist, working with the primary care doctor to put together a plan both to manage the anxiety, manage understanding the next steps. But I can't treat the anxiety while even in therapy if we can't get those blood sugars regulated either, because that's going to take a whole chain reaction as well with the anxiety. So knowing we all need to be reading from the same playbook, and also knowing this is a patient who would never have sought mental health care and never even really identified some of what he was experiencing as anxiety, had he not had a group of us to help him name it and put a plan together.
Good, thank you. Dr. Wren, you want to give us a little bit of information on you?
Sure. So I'm a family physician. I had the good pleasure of working with Dr. Zazoff for over a decade at Family Medicine. So Dr. Zazoff and I go way back. And I think in some ways, you know, when you hear about integrated health and you're not in the field, it makes such intuitive sense. I think you would wonder what the big deal is. So, you know, I want to actually go back to when I was at U of M and tell you a couple stories I think that will help illustrate why we are still talking about this. So, I remember around 97, I had a patient who had a significant mood disorder and bad lung disease and got put on prednisone, right, a steroid which is not necessarily stabilizing for mood disorders. And I got a call from his psychiatrist, and I remember this because it was the first time it had ever happened to me. I started medical school in 1982. This was 1997. Okay, so a couple years later, someone else who had both significant mood disorder and significant physical disorder, something was happening. They'd gotten their medicine changed from their psychiatrist, but they couldn't remember what they did. So I was at U of M. You know, U of M got a pretty nice electronic record right around 97 called CareWeb. So I thought, I'll look it up. I got this computerized record. And I go in there, and there's no psychiatric notes. I probably called Phil up and said, where are the psychiatric notes? You can't see those. You're not allowed to look at those notes if you're not a psychiatrist. Okay, so that was the state of the art. This is, you know, in Ann Arbor at a major medical center. So a lot of what we're trying to do really is just break that down, both through technology but also through the professionals working together. That sounds really easy, but it took me 15 seconds to say it. And it's not easy. It's hard work. I've got to warn you, Tim Florence and I go back on this, and we've traveled around. So we have there's a big divide. There's a big cultural divide. It's not good or bad. It just is. And this really is trying to get professionals who are trained a certain way really to interact in a different way. And the benefit is, right, we walk around and we have a brain and we experience reality through our brain, and then we've got all this stuff south of this, and, you know, we think it's all tied together pretty closely. But, you know, that was really what we're dealing with relatively recently. Not only were they not talking, you couldn't even see what the other was doing. So, you know, I tell folks I'm a true believer here, and, you know, I haven't traveled around the country and looked at all the different programs. I will say, if you've seen one integrated health program, I'll show you the simplest one. And go Wings, but I actually ran into a gentleman who ran an integrated health program through his cell phone. Yeah. What it was is, if you're a family doc and you've got a problem, you call his phone, he'll pick it up right then, and it'll help you out. So, you know, that's in its simplest form. We all have it. So, but there's lots of models, and I'll stop now because I can go on like this for a while.
Do
So.
you have one for the tigers?
I don't actually, but I would take one if you've seen one.
Yeah, but you can only use it for leading up to the All-Star game, because after the All-Star game, you know what's going to happen.
Go back to the woods.
That's right. Dr. Zazoff?
I don't have much to add. I just want to say one thing. First, what Ray said about the electronic medical record is better. But part of the problem is that people are very, they don't want their information to be available to everybody. Because mental health has this 1,000-year history of taboo in the old days when if you were depressed, you were crazy. I remember when Tom Egerton, I think it was Tom Egerton.
Yes.
Yeah, Tom. When he was McGovern's running mate back in '72, admitted he had depression, just like any other medical problem, and that was it. You know, so in those days, that he was gone. Because to me, mental health is a physical problem. I don't. For the most part, I think it's more physical rather than a separate problem. Because the more we learn, the more we know that when you have a mental condition, regardless of whether it's anxiety, bipolar, schizophrenia, depression, your chemicals in the brain are different. And we've shown that again and again. So I think we need to start putting things together. There is somebody, and Ray knows him, and maybe you do too, named Mike Klinkman, who has actually done a lot of work in integrated healthcare here in Washtenaw County. It actually has a lot of promise. It's called MDOC, MDOCC for Michigan, it's focused on depression, Michigan Depression Outreach Care Coordination. And basically, if I have a patient who's depressed, probably a third of my patients are depressed, but someone who's significantly depressed, I can hook them up with MDOC, it's free. And the social worker will call them at least once a month, more often if need be, and do what we call a PH29, which measures how the depression is. So I know if they're getting better or worse. If there's a problem and they need to see a psychiatrist because they're suicidal, they will expedite that. So I don't have to get on the phone and try to track somebody down and find out that nobody can see them. You guys know how that is. And so it has a lot of promise. And it's a joint effort with the University of Michigan Psychiatry. Now, MDOC is only available to people in the university right now. So that's not good. I don't know if you have MDOC.
Not yet.
No. So that might help. It's not going to be the cure because depression is only one of many psychiatric problems. So I think we're making progress, but I think we've got to move away from thinking that mental health is separate from physical, because it's really, in my opinion, tied together.
A little later on, we're going to have questions from the group, but I want to raise a few questions with you as well, in a couple of different areas. I want to piggyback on this issue of integrated health in the sense of the Michigan system, where you have a way to connect with one another. Dr. Ryan, you are outside of the Michigan system. You are at Packard. Now, if you have a patient who presents to you with symptoms of some sort of whether it's depression, whether it's a mood disorder, can you contact the University of Michigan? Do you have a way in to find out the health background of this person, to find out what medications they will be taking, or are you flying blind?
So we have the ability to access both St. Joe's and U of M computerized records. So that has gotten a lot better over the last 15 years. So we're not in, the electronic equivalent of the dark ages. So a lot of the electronic barriers have gotten better. So what we've done at Packard is we've actually worked with CSTS and have had a MSW, a full-time MSW actually on site. And actually, Dr. Florence has worked with us for around 9 years now, a half day a week. So we've got in our office a full-time MSW and a half a day of a psychiatrist. So we tend to use for quick backup, rather than the cell phone, we walk upstairs and talk to the social worker. So that was how, a lot of, and so the term for that within is they call it co-location, right? You're together. But what you really need is you need sort of integrated conversation and the ability to work together and understand one another. And then like all human relationships, they go better if you know one another and you have an established relationship and, there's some time and trust there because it's different than the standard model everyone's trained in. That like a lot of things builds over time as people become comfortable with one another.
Okay, then I want to ask Danielle and Phil, given that you're affiliated with the University of Michigan system, how does it work when you interact with docs from St. Joe, or when you end up with a patient that has spent most of their time in the St. Joe system? Is there a connect there? Danielle?
Well, being a social worker, yes, I mean, the electronic medical record is still, I think, a work in progress. Coming from the background in Minnesota, I know that there is a feature that will be coming that is called Care Everywhere, which is once a patient's release their records into Care Everywhere, anyone who's in that electronic system can access them, which is really a lovely feature of the electronic medical record. So that's coming, but for me as a social worker, the common denominator in everything is the patient, and so if I can access the patient, I can get most of the information. I would prefer most of my information to come from them if we can make that happen, or their family members, because that's really, they're the constant in all of this. But then, obviously, then it's the co-location, or, that consultative relationship where you pick up the phone and you fax over releases and you try and get a hold of somebody who you can talk to about what's going on and what the plan should be.
Phil, what's your experience been?
There's an agreement between UM and St. Joe's to share the medical record in terms of everything gets faxed and scanned within 24 to 48 hours. So it's there, you just have to know how to find it. The problem for me is not that, it's when they get admitted to Brighton Hospital for substance abuse, or they get admitted to someplace else, and they come back, I have no idea what's going on.
Right. Well, and then the follow-up would be, I'm from a little town of, it was 1,200 people when I lived there, and it's actually gone up and is going back down. And they have a part-time doctor, a doctor who comes in. It is not the medical resource heavy kind of environment that we enjoy there. How can a doc in that situation even begin to build a system where they're going to be able to address the sort of the whole patient? So you've got a doctor who is not necessarily trained in mental health issues. Maybe, what do they do, a semester, a term or something? You get a little bit of it on your rotation. For people in those kinds of situations and doctors in those kinds of situations, what's the model? Or is there one?
That's a great question. It's going to have to be some sort of telemodel. The model as it exists is somebody travels, right? The patient travels. You get the standard is you get a referral model. They either help you travel to, the big city, or else they give you a number and leave you on your own. So it's a little bit like HMOs. The other thing that's fascinating is, the HMO mental health carve-out, right? So if you have Blue Care Network, there's an 800 number you have to call. So that's how you get your mental health care, is you've got an 800 number. It's not dissimilar to that, where it's just a referral model. I don't know. Tim, have you heard of any sort of distance, little town integrated health programs? That's an interesting one, Lynn. I haven't really run into that.
It's a tough one. I don't know of any well-developed models, other than trying to lay down certain kind of networks and then teaming kind of with a virtual village of sorts. But no clearly established rural models I'm aware of.
Let me put a scenario in front of me, or in front of you, and then explain how each of you would handle it. You have a young woman, 24, she's got 2 little kids. She shows up in your practice, sort of out of the blue. She is depressed. She really doesn't know where to turn, what to do. And she turns to you, help me. Now, this is a person who's depressed, which means anything you hand her to call from, it's going to go in the trash. She's not going to take any action. What can you do to help her? How can you begin to integrate what she needs into sort of a full care system for her? What are you going to do, Dr. Ryan?
Well, I think the first thing you have to do is assess whether people are safe, right? I mean, if people are a threat to themselves or others, you've got to get them. So, you know, you have to first do some basic assessment on, are they safe to treat in your office? Do they need emergency care? And that's the first cut. If they are safe to treat, then it's more how severe are they? What sort of supports do they have? In primary care, I would say our standard is, you know, mild to moderate depression, mild to moderate anxiety, you know, what's called adjustment disorder. Somebody gets a divorce, somebody gets, you know, laid off. That's really fundamental, I think, what most primary care docs are trained to treat. So again, if she's, say, mild or moderately depressed, typically someone would start some type of medication. And, you know, at least if people are more severely depressed, with some talk therapy in it. So, you know, that's interesting because the talk therapy is going to be driven by insurance coverage, right? Where they can go, what network they're in, that kind of stuff.
And that's another area I want to get into in a minute. But let me go back to this young woman. She comes into Packard Clinic. You decide maybe there's more needed here than, you know, a simple low-dose antidepressant or whatever. Where do you send her? In other words, do you hand her off seamlessly? Do you have to give her lists of places to call? Does she now have to find somebody who will see her? Does she need a referral? How do you move her into the care that she needs?
Well, we actually wound up moving a lot of the care system into Packard.
So you have it on site?
Yeah, so we take care of, you know, moderate to severely depressed people. Again, if I'm feeling like, wow, you know, I'm kind of a little bit out, you know, people got to know their limits, right? I mean, that's the most important thing in life is to know your limits. So if I'm there, you know, the first thing I'm doing is talking with my MSW to say, gee, Amy, you know, can you go, you know, if I'm not sure someone's safe or I think I'm really getting in over my head, we can call her in quickly. I mean, like 10, 15 minutes and have her in the room. And that's been just, number one, a lifesaver, and number two, it gives in a single location, it's kind of like a menu button option of skills, and it gives you a bigger number of menu buttons to bring in.
So you built a system on site?
We did.
But
and then, you know, she's got Dr. Florence on speed dial. So if she feels like, wow, this is, you know, not only is he over his head, I'm feeling a little, you know, then she gets Dr. Florence on the speed dial.
So again, we're in a resource-heavy
We are.
environment. So if you're a solo practitioner who has admitting privileges to the regional hospital, doesn't have a psychiatrist on speed dial, doesn't have an MSW that he can call from upstairs, then what happens?
You know, then you work with and it's really hard if they're uninsured, because then you're really having fun with that. But if they have insurance and they need talk therapy, you refer them, you know, out through their insurance to a counselor, and then, you know, hopefully there's some communication around that, but that's not always as smooth as it could be either.
Okay. And Danielle, when you were in that situation, what are the steps you take?
Well, I'm the social worker that gets called in, I think, in those crisis moments and tries to figure out what kind of crisis is it, if there are children involved. Do we need to get someone to come and take care of the kids so that we can get her hospitalized, or is the question more about short-term, long-term kind of treatment plans? More often than not, I think that what I'm seeing is that it's something that, like what you're doing at your clinic at Packard, is that, you know, moderate to
Ever, I'm paying directly for my medications. I was staggered when I found out that one of my antidepressants, a 3-month supply, is $845. Okay, now, I have a health savings account that ultimately I can reimburse myself, and even if I couldn't, I'd still be okay. But for many people, that would end any thought of getting treatment. That would end any thought of getting on antidepressants or getting on blood pressure managing drugs or anything else. So how is that affecting? How is that affecting the people that you see? Phil, what's happening with that?
It's a very complicated question.
Thank you.
So there are a lot of components, but in my experience in Dexter, I'm seeing a lot more new patients because of the Affordable Care. People who didn't have insurance before. I'm also seeing a lot of people saying they can't, like you said, afford, not so much because of the ACA, but because their employer got now at Michigan, we've gone from $15 to $30 in the last 3 years copay. And that's a lot of money for somebody who's making $25,000, $30,000 a year. So that's a short answer to how that's affected. There are a lot of other things too, like the drug companies who we don't accept any drug detailing, but some private docs do. And they leave samples, and then you give the patient the samples, and then when they run, they get the prescription, it's the $145. And sometimes that's the only drug. But I think one thing is to think about generics. Most generics, but I would say 80% of mental health drugs now have a generic. Like only 80%, but that is 80%, much cheaper. You're talking about $30 versus $800.
So what you're saying is that the doc works with the patient to figure out what can we find for you that
That's
you can
exactly
afford.
what happens all the time. Sometimes they can only be, they've tried all these, or they're on a brand name that's the only one in the class. Then you have to work with the insurance company, or you work with the drug rebate programs, or you work with whoever. Sometimes it just doesn't work. And then we're kind of in a difficult position. When I did my sabbatical 11 years ago in England and London, it was so different. Not one time did anybody ever think about money for patient care or medication, because you got covered.
Yeah, I never did until I had to pay $845 for my.
But it's so different there, and people get what they need. But anyway, it can be difficult.
So Danielle, when you work with patients, you were talking about anxiety around managing a condition. Do you see this kind of anxiety from
sure.
folks?
Yes, absolutely. And it's hitting right at the heart of what social workers are. I mean, part of what we do is trying to help people access their care and have it be affordable and figure that out. It's not always possible. It really just isn't. That's the reality of it. And yes, I've lost patients but having them fall out of care. And I try and spend a good part of, or at least some part of my week every week of a full-time job trying to track some of them down and kind of reach out to them by phone and connect them that way. It's not nearly sufficient as therapy or as, being able to follow with medication would be, but I could probably even start to name names if I wanted to of the people who I really wish that I could scoop back up and get back in to some sort of program or care, but they can't afford it. The Affordable Care Act has helped. I think just even in the 6 months that I've been in the clinic here, I've seen a lot more people get access to coverage and care that they didn't have access before, and they have a little bit more medication option within that. But there's also a group of folks with the deductibles. The $700 deductible is you can't do that. It doesn't work.
Well, one of the things that happened as a result of the Affordable Care Act that I think was very surprising for a lot of people who were waiting to get coverage, they expected they would be under some sort of private system, there'd be a subsidy, everything would work out in sort of a private care system, and they were shocked to find that their options were going to be an expanded Medicaid program. Now, there have been problems with Medicaid over the years. We now have more people having to use that option. How is it for the kinds of things we're talking about. Healthcare in general, mental health care in particular, are the reimbursement rates adequate? Are people going to get the sort of care we would hope they would have if they're in Medicaid or on the extended Medicare program? You deal with that probably more than anybody.
Yeah, so the Affordable Care Act has been just an absolutely fascinating change to go through, and we're not through it yet. About a third of our practice had the county health plan, Washtenaw Health Plan, so by September that's going to be about 20% of the size it was as of January 1. So we're having a lot of patients really having their coverage shaken up. Some of them love it, right? The guy who gets Blue Care Network through the exchange for $25 a month to get the what is it, platinum, I think. He loves it. And then you get the person who's getting the big deductibles and you don't see them much. Actually, we've had people disappear. So I tell you, as we went into this year, we made all these projections that life was going to be great, and then some subgroup of people got sticker shock, and that was not something I expected. I think one generalization it's very safe to live by is that standard Medicaid doesn't cover the cost of providing the care in most instances, and certainly when you start dealing with Medicaid with the mental health system, it's extraordinarily overloaded. And services are hard to get. It's kind of get in line. If you can find someone, then you get in line. So access has always been a problem. That's actually, Julie Walden really, I would say, is the architect of the Packard Integrated Health Program. And I can tell you that's part of the response. That's partly why. It's just the system was so overloaded. So in primary care, at times, I'll be honest, you felt a little trapped, right? You were here with people who are more complex than you could really deal with, and you needed some help. And Julie and Kathy Robinson really made it happen at Packard, I think, for a lot of people's benefit. But yeah, it's safe to say that the system's overloaded.
So if our hypothetical 24-year-old mom with 2 little kids and a fairly deep depression is on Medicaid, what happens then? She doesn't have nice health coverage. She can't go to her U of M doc and get handed off to another professional within the system. What happens to her now if she's on Medicaid?
I think if she's in a standard practice, they will try to refer her and she'll queue up. And then, you'll have a primary care doc. And, primary care docs write probably 80% of all antidepressants in the country. So they're really providing the bulk of the depression care. And then, they'll do the best they can given the limitations of the system. I would argue that's part of why integrated health programs are a superior model. Because you avoid that delay where either people don't go from either system to the other, or they go and they get into this queue and there's this big lag in receiving services.
I don't think there's enough psychiatrists or primary care docs to handle the load.
Yeah.
That's the problem. And if you look at the average medical student, they're graduating something like $230,000, $240,000 debt when they graduate. They're, for obvious reasons, picking specialties to pay more. And so I think part of the problem is there's just not enough of us. And all these people come in and we're overloaded. And so when I call, even through MDOC, you try to get a psychiatrist, it's very hard.
And of course, most of the people in the room, that's where they rub up against the system. That's where they're finding the difficulties. Okay, yeah.
Can you walk through the process when a patient comes in? Do you screen everyone, or do the physicians refer to you? How does that work?
So the physicians refer. Absolutely, I think there are more than 6,000 patients that come through the clinic every year. So 10 physicians seeing patients at 20-minute intervals. They refer almost all of them to me. And they have screening processes. They use like a PHQ-9 or a GAD-7, so to assess for depression or anxiety. sometimes it's a hunch, sometimes it's that you're in tears and talking about some horrible circumstances with your doctor. When there's an acute crisis, they'll come and knock on my door no matter what I'm doing and say, this person seems like they're in a major crisis. That doesn't happen very often, but on occasion, we need to try and get them into the hospital today is worthy of interrupting anything I'm doing, whether it's by phone or in person. But then from there, a lot of the time on the way out, I have a great front desk staff that will say, I see that there's a referral for Danielle. They help get them on my schedule. I almost always, within a week, have availability to see a new patient for what
full-time?
Full-time in the clinic. I think one of the few social workers who's full-time in one place within the health system.
Okay, so the health system, you said some patients you bill when you can, but others you just, so the health system must subsidize your salary then?
Yes.
That's how it works, okay.
Are you part of my PIP?
No.
I think you are. Okay, so, about 2 years ago, one of the faculty got a grant, and we're one of 8 states in the country that partnering with CMS, and they are paying us upfront for social workers, like we have been to for PharmD people, for nurses, chronic care nurses. But it's only a 3-year program, and we're in the 3rd year now. So I don't know, nobody knows whether we're going to continue or not. And that's why in the past 2 years, including her side, everybody's having social workers and PharmDs, and it's really been wonderful. Question is, will it continue? When CMS has to decide. And what CMS wants to say is, do we save money by keeping people out of the hospital and out of the ED by paying more upfront? Which the preliminary evidence is that we are, but we won't know for a while.
I think there are 2 parts to it. The cost savings part of avoiding certain levels and degrees of care that are costly, but then there's also, being new to the health system and new to what I'm doing and tracking insurance and what I can bill and what I can't bill, I would say that probably only about 10 to 15% of what I'm doing every day I can't actually bill for. I can't tell you reimbursement-wise because I haven't been there long enough to actually see, but I'm seeing enough to say that I think that there's a good portion of my salary that I actually am able to bill for. So in addition to there being some funding out there for avoiding cost of care and some support for that, there really is. If you balance your workload and caseload well, it does sort of offset itself a little, at least to some degree.
Yes, Len.
I'm going to describe a situation that I think doesn't work and then ask if there's some way that is planned to make it better. In our healthcare, we have a primary care physician, and we have one family member who does have mental health issues. Our primary care giver is very well aware of that and communicated. On any healthcare issue, which is really important, we need quick attention. We never get our primary care doctor. We have to wait 3 weeks if we want a specific doctor. So that this integration across the ideal of one caregiver who understands the family unit and the individual members, I think is great in practice, in theory, but absolutely broken in practice. Never happens if we need immediate attention when we most need that information. If I'm on a routine checkup that could be done by a medical student, then I can get the well-informed primary care person.
So,
Go ahead.
You're absolutely correct. And there is a movement nationally called population health, taking care of population. Where rather, right now, I get paid, other than the MyPIP thing, which is a small part, I get paid for seeing somebody. And so, people who want to come in, I know they don't need to be in, I still get paid for them. There's no incentive, in fact, there's an incentive for me to see them, rather than not to see them. In the population health, the whole idea is you pay people X amount of money to manage the population. For the people with the strep throat, the sore throat, I don't need to see them. I can have a nurse practitioner. I can have in fact, we have a pharmacy doing it now. And I can see the people who are, got the anxiety about the diabetes and spend 3 times as much time because it's not affecting my salary. The problem with moving there is until you get paid that way, you can't afford to change. Because if I start doing that now, I go broke.
But I think part of what you're asking about is the primary care physician is gatekeeper. And when you need the gatekeeper, when you need the primary care physician to move the patient into another area, you're saying you can't get in to see your primary care doctor?
Well, we get a family member with the anxiety and paranoia needs a gentle, receptive, aware caregiver. And that takes some foreknowledge helps as opposed to the family member walks in and the physician assumes this normal looking person is normal in a mental health sense and probably isn't thinking that the filling has a microphone in it or that any other thing is some real threats unless trust has been built. The trust is built in one person in the clinic who can't see her on short notice.
And that's what I'm hoping the population has to 3 people left so they can see you or that person, theoretically at least.
I'm going to go back on something that you said, Dr. Ryan. You said that 80% of all antidepressants in the country are prescribed by family care physicians. One of the things that I have always been concerned about, and I'm not sure that it's changing now, is that while medication is important, we were talking about brain chemicals earlier, therapy is important too for some people, particularly people who've struggled with mental illness for a long time and have developed all sorts of dysfunctional coping mechanisms that have to be undone. How easy is it to actually move a patient into therapy? I mean, I look at my situation, psychiatrists don't even see patients anymore. They manage the prescription work of various MSWs and whatever. Are there people, I see, Danielle, you say you see people for brief therapy. Mm-hmm. Is there therapy out there? Can people access it? Our insurance coverage actually providing for that? What's the status of therapy these days, and how does that fit into your integrated health model?
You want me to talk?
Well, so you'll get a family doctor's version of that. The insurance is, it's, you guys know the golden rules in healthcare, right? Who has the gold makes the rules. And so the insurers and the government have the gold, so you follow their rules. So, they'll set limits. I don't know them, you may know them, but each insurance will have a limit on how much therapy they'll pay for. And then if you're uninsured, then you're looking for someone that'll do it on a sliding fee scale. There's a few around, and again, you're generally going to get in the queue for that. And Medicaid, again, I think we have resources in our county, but I think a lot of it's insurance driven and how rapidly you can access that. I can tell you in primary care, we basically do sort of supportive therapy. It's like being, patting people on the back. I mean, it's really just sort of support and then, refer out for really any sort of deeper therapy. I think at least most of the data I've seen is that people who are moderately, severely affected can really benefit from talk therapy. Milder anxiety, milder depression, I think the data is not as clear. And then the insurance companies limit that, frankly, because the drugs are cheaper than therapy, right? You can get antidepressants for $4 a month, $10 for 3 months. So that's really what's happened in why they've shifted their amount they'll pay for down.
Right, but we're still left with the question, which is, Danielle or Phil, you have someone who clearly needs talk therapy. What are your options there? If the answer is the health insurance folks are going to keep them out, the Medicaid people are going to keep them out, I mean, isn't that a huge gap in our integrative system?
For me, it's very hard. I mean, I agree with Ray, but there are a lot of people with mild to moderate who want therapy.
Right.
And to find them, I mean, it doesn't matter who I refer them to. It's very hard to get in, mainly because when they call, they can't get in or they have a long wait. It's the same with us. I mean, they're just not accessible, or they can't afford it. It usually comes down to one of those two things. And maybe, we have a social worker too, and she's good, but she can only do so much. And she's only with us 12 hours a week. Because she goes, like you said, she goes between different clinics. So I have a problem finding that.
One more follow-up, then we'll go out back to the audience. When I read your bio, Danielle, and you talked about brief psychotherapy, the thing that came to mind is we're a university community here, and we have lots of students, whether it's at this university, Eastern University, or colleges or whatever, lots of kids with problems, and depression on university campuses, huge problem. Does the university have any way to address this? My stepdaughter, for example, going through a divorce, all kinds of problems, severe anxiety. She goes to a counselor. Counselor says, okay, well, we can talk this through, whatever. Now I can't do any more for you. You're sort of on your own. Do we have a way of dealing with young people who have these problems? Kids who are in college, who may get a little bit of help at student services, and then what?
Right. And then what? I mean, I don't know that a lot of them make it out to the clinic where I'm at. I don't see as many of the student population out there to speak real well to that, but I think that they end up making their way to some of the places in town that do sliding scale services, or some of the community clinics that are willing to take people who maybe don't have coverage or don't are underinsured.
Ryan, Dr. Ryan, do you see some of those folks at Packard?
Sure, yeah, we'll see, we see, we're closer to Eastern probably, so we probably see a few more Eastern students. And, we're hooked up fairly well, at least able to give them resources, because, that's a big part of our business.
Well, instructors will get these fairly cryptic little messages from the college saying, this student is dealing with certain, it's very euphemistic, is this some kind of problem? They will be contacting you in the future, please, which means this kid's in trouble. This kid's in big trouble. I have about 80 kids per term in my class. I get at least 3 of those every term, which suggests that we have a real problem on campus with kids in trouble. So, all right, there are other hands here. Yeah, Jerry.
I guess, is it Glenn?
Yes.
I guess I'd like to come back to Glenn's question just for a second. And Danielle, you need to weigh in on this too. In the old days, as I've heard about it in family medicine, docs work till till 10 o'clock. So why, if Glenn lets you know that his daughter needs to see somebody, I mean, you do this, I think, Ray, stay late and see. So, and are you flagging some charts, Phil, that this person has to be seen by their provider when they come and when they call? Or can they see you, Danielle, and then you say, well, this is a big problem. You got to see Ray today or Phil.
The docs that I work with, whenever they can, will double book themselves, will do what they can to fit people in, but a lot of the time what people are faced with is that the docs have already double booked and triple booked themselves and are already scheduled out to be there till 10 o'clock that night seeing their patients. And
They're really there till 10 o'clock?
I definitely have a couple of docs in my clinic that are quite frequently there much later than...
Okay. So we don't go to those docs. There must still be an answer to that question, I think, because that's what you guys are trying to do, is to integrate care.
I think some of it is about also creating a team that, I mean, when we're talking about integrated care, you have to create a team of trust instead of just having one person that you trust. You have to have a team that you trust. You have to have a clinic that you're comfortable with, that you can, I mean, I can only speak for even how I want my own health care provided. That I want to know that if my doc isn't available for whatever reason, that his partner is someone who is going to take care of me in a way that I'm accustomed to, that clinic provides care in a good way, in a way that I'm comfortable with. And I think that that's what we hope for our family members when we have specific concerns like that. I think that those are the cases that I would hope that the docs feel like they have a social worker or someone who, even if they can't be there, that could be there alongside of the patient, alongside of the family, to add one more comfortable, familiar face, who could maybe preemptively talk to whoever is going to see that patient and say, here are some things to keep in mind before you walk in that room.
See, the network's fine for me. I don't expect to see my primary care giver when I call. I don't. I always ask. They always say, check, 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 check. 3 weeks is as soon as we can get to it. And then I say, I need to see someone right away. And then I get someone within a day or two. That's what I expect. I'm okay with that. I go in, I've never seen a person before. I trust they're a member of the team. Doesn't work for the family.
I'm going to just throw out one more thing, that we don't have anyone sitting up here that's on the panel right now, but the other way that this integrated care we're trying to provide it is also to bring primary care into mental health settings. And I think that I think that there's at least some groups doing some of that here in community mental health, of making sure if you can't get into your primary care doc, but you can get in to see someone that you are comfortable with, what are the different ways that we can do this? And if you have a psychiatrist that you're comfortable with, or you have a social work clinic that you're comfortable with, and they have someone who can help, a nurse practitioner or someone, again, that's a familiar face, that's a comfortable place to be in the scope of whatever mental health you're dealing with. So I think that the idea is really that we're doing this in a couple different levels and in a couple different ways.
Okay. Catherine, you had a question?
I had 2 questions, because I've had some long-held assumptions that were just contradicted. And I want to confirm what I'm hearing. One has to do with insurance. And I had always been told that, well, if you have the county plan or Medicaid, or even Medicare if you're older, that you can't always get coverage. But if you have private insurance, the Gold Star being Blue Cross Blue Shield, that you can always get coverage. And I think what you were saying is that's not true. They have limits on number of visits, and if you could expand on that a little bit.
Oh, it's it's mind-bendingly complex. At Packard's 30th anniversary, Jerry stood up and said the billing part of medicine is harder than the medical care of medicine. And if you want to track what insurances are covering, boy, get ready, because your head is going to be spinning. In general, they cover less and less over time, but they all have limits on how many PT visits you can have in a year, how many therapy visits you can have in a year, and then maybe there's like an appeals process you can go beyond that.
Yeah, I mean, it's really kind of baffling. I thought the harder part of me figuring out how to integrate with the care team at the clinic was going to be about names and faces and diagnoses and care plans, and it's really been a lot about billing and insurance and coverage. Some people will have 10 visits, some people will have 20 visits, some people will have $700 deductibles, and they don't have to pay anything out of their deductible to see their primary care doc, but they would have to spend down that $700 to see me, which is mind-boggling to me. But
even under parity,
Yes.
under the federal.
if you have a $700 deductible for specialty care, then it's $700 deductible for specialty care. And I'm specialty care.
Well, why would mental health be specialty care if we have parity with physical health?
Well, I mean, specialty care being like if you were going to go see a surgeon, or that, that psychiatry and mental health care is for some insurance policies, the same as going to see a surgeon or going to see a higher level, what they call it, a higher level of care than primary care.
Okay.
There is meant to have parity, but they can pick, insurance companies, I used to be medical director of MCare, and so I know, I mean, people look, how MCare is really unique, but I was familiar with some other places. Some of my co-medical directors came from Aetna and Anthem, and they got out front. The goal was to minimize the number of visits and make money.
Yeah, parity is treating everybody poorly.
And so even though you have parity, they figure out,
Because it's special.
Okay, so
Yeah,
then the
that's
other widely held assumption I've had forever and ever is that some generics you could substitute very well, but the common ones, now I don't know if it's antibiotics or whatever, but that some of the more esoteric medication you couldn't really substitute generics that well, and mental health medications were one of the poorer ones to substitute. Now, maybe you could just clarify what you were saying earlier.
So I would think mainly 3 or 4 things. One is antidepressants. There are probably 10, 15 generic antidepressants now. Maybe some people do need some backup because that's the only one that works. And that is very expensive. But rather than go to that first, have you tried any of the other 7 or 8?
Okay.
And bipolar, lithium. If you talk to most of the psychiatrists, they'll tell you lithium works as well as some of the newer drugs. But people, for some reason, continue, psychiatrists as well, prescribe the newer ones, which are very expensive. There are several examples like that that I was talking about. Having said that, very clearly some people do need, either there's nothing available for their condition or they need something that is only a brand name, and that's appropriate, but it's also expensive.
There were certainly concerns, I'm not up on this right now, but for a long time, what I heard from consumers and from doctors is that formularies used by Medicaid essentially put a lot of the newer drugs, they didn't pay them, they were off of the list, and people were using the less expensive but older kinds of antidepressants, psychotropic drugs. Is that still true? In other words, is Medicaid more restrictive even than the private insurances might be around generics and around the use of drugs?
Well, probably wouldn't know more than me, but I haven't noticed that lately. They seem to be reasonably.
Okay.
I have about 10%, only have about 10% Medicaid, so, yeah.
So they all have formularies now.
Right.
I think Blue Care Network has 5 tiers or something. I mean, it's like,
Yeah.
remember when it was like tier 1 and 2? I'm like, oh, okay. Seriously, I think they've got 5 now. I'm not making this up, and each one is more expensive. And having said that, none of the insurers like to pay for expensive drugs, so they'll all make it difficult to access.
And so you wouldn't see Medicaid as being any worse than
They're
many
certainly
other
not
programs?
better.
Well,
Yeah, they're certainly not better. I would, again, they just have fewer resources, so they're going to have a tighter formulary than a lot of the standard private insurances.
I saw a hand back here, yes.
I guess this question, how to move closer to an integrated model if you're not in a clinic that does that with a psychiatrist and a PCP that you already have that practice in the same town but don't know each other.
Do they work for the same entity like U of M? No.
But there's issues sometimes that fall in the middle, for example, like a thyroid condition.
Sure.
That is correlated to mood disorder, but the PCP monitors it, but I'm taking things from my daughter's MyChart and exporting PDFs and emailing them to the psychiatrist, and it seems crazy. But I wondered if you had any suggestions on how to better manage that.
Do they perceive a need? The 2 professionals involved? I'm just curious.
I don't know. I just wondered if it's appropriate to just put out a blanket email, so-and-so, could I introduce you?
Well, I would.
Provider matchmaking.
I mean, that's one way. I think that's just a style issue. Whether you could probably text them. You want me to text them now?
How would you feel if a patient did
I'd
that to
actually.
you?
So I'm kind of at one. I think it'd be pretty refreshing, actually.
Oh,
Yeah.
okay.
Yeah.
You wouldn't consider it an extra workload, you know?
So to me, it's a little bit like the more active someone is, the more important that is. But I think if someone said, listen, you don't even reliably get information back and forth from psychiatrist to primary care. Every time I send a patient to a cardiologist, I get a letter back. I mean, I've got some people seeing psychiatrists, I've never gotten anything from them. So, the communication even now is often significantly poor. So I think I would suggest it to either one of them who's more open, and then go suggest it to the other. Then I would do the email. Yeah.
Okay,
Yeah.
all right, thank you.
Yeah.
Hi, my name's Kelly Stuffel. I'm a child health advocate with Success by Six, and I'm based at the Washtenaw Health Plan. And I was wondering if it's appropriate if we could hear from CSTS, because I know that much of the Medicaid care goes through CSTS, and I do a lot of referral to Access. And I was wondering if they could talk a little bit about their process and how things are working, and if they've seen changes with the healthcare reform.
I think that would be very helpful.
If you're willing to do that, Tim, we can just pull a chair up here.
So, yes, is the,
You can become part of our panel.
over here.
Actually, Tim, come closer because we have a microphone here and we're recording.
You may be part of the panel.
Yes.
So, all right, so I'm temporarily an ad hoc member of your panel. So CSTS is responsible for providing mental health services for people in Washtenaw County who are uninsured or who have Medicare and who have a level of a mental health condition that leads to certain degrees of functional impairment, difficulty doing things in life, whether it's with relationships or work or school or things that lead to interactions with the courts or the criminal justice system and the like. So for people who meet that degree of severity, there are a number of resources. Many people seen in the clinics that you see represented on the panel don't. And this is one of the issues, and one of the reasons why, as a community, we're working on something, one of the things that's going on is something called the Washtenaw Health Initiative, which is trying to look at how can we, in Washtenaw County, create one unified, organized system of care, period, right? So, grandiose goal, progress is being made, we have a long way to go. But if you have a serious mental illness, a developmental disability, a youth with serious emotional disturbance, and meet criteria for community mental health services, then you will likely get served by a team of people, including psychiatry, nursing, case managers, or social workers. For us, Medicaid, on the mental health side, has an open formulary.
Oh, okay.
Which is great. And if you have Medicaid, you have a defined benefit. If you meet medical necessity criteria for a whole, there's a whole slew of different kinds of services and interventions available under Medicaid, but it's a defined benefit. So if you meet medical necessity criteria for anything, whether it's medication management, whether it's certain kinds of even in-home support, it has to be provided. That's part of the contract. So the interesting thing for me on the carve-out side, the deep end serious mental illness side, is that if we have people who burn through their private insurance benefits and therefore come to us, even if they're kind of insured, even if that benefit's still active, it's harder for us to get services because there are no defined benefits for case management and in-home supports and all those kinds of things that do exist on the public plans like Medicaid.
So how difficult is it to reach the level of medical necessity?
It depends. You know, it depends. It takes a lot of training to learn how to operationalize criteria. It's a, you know, health insurance is a remarkably complicated system, period, no matter what you have. And, you know, we see people with multiple different layers of insurance, and if this doesn't cover that, then go here, but if that doesn't work, then you might hit this donut hole of coverage, or, you know, all these kinds of things. So it's just terribly complex. So for us at CSTS, so there's a 24-hour phone number that anyone can call. It's our access phone number. We'll get a live person on the other end. So if you call right now, you'll get a live person on the other end. There's a triage team that's run out of our Ypsilanti site. And they'll, you know, take your information. If it's someone's calling in crisis, there's a crisis group that can respond. If you call and and on that screening, it appears you have a serious mental illness, developmental disability, you'll get scheduled in for a full assessment. Lots of calls come through for people who don't meet that criteria, and then what Access will try to do is to figure out the vast complexity of resources in our community to try to get you connected to the right spot. So that's hard. You know, that's just hard. And it's really hard, I think, to find psychotherapy if you have mild to moderate illness, or psychotherapy, even if you've got a benefit, it doesn't mean people are going to take your benefit. So waiting lists can be remarkably long. So when referring out, you know, we're always looking at, you know, who's got openings, where are we with the training programs at EMU, at U of M. Sometimes that's another avenue in. You know, the nonprofit organizations in the community that provide psychotherapy do really good work, and often are the places with the sliding scales too. So we'll often refer there as well. So complex system, you know, at CSTS, someone is now going to pick up the phone. I'm delighted that there's, you know, at least that single point of access that way. But not everyone even knows the call, and I'm sure there are people here who didn't even know that existed. Which is also why we want there to be kind of no wrong door, why we are in primary care safety net clinics, because people know if they've got a primary care doc, that's someone who's there who has took the oath of, you know, do no harm and try to help, right? And lots of people that we should be serving in community mental health might go there. But if that's the front door, we need to be at that front door. Or if people are just too sick or disabled to know that, I mean, you know, that they can even come into a clinic. That's why we have outreach teams, you know, and we're big fans of, you know, the saying that an ounce of prevention is worth a pound of cure. And the earlier in someone's illness that we can get them, the better likelihood we have of helping them and to stave off disease progression, which happens in mental health conditions as well as physical health conditions. So that's why we have, you know, our homeless outreach teams and our jail diversion programs, and why we have our staff in the jail. And why we're trying to put more staff where the population centers are, and why we've, you know, kind of done a mapping of addresses of the people that we see, because we want to put our staff where they can be most efficient as well as most effective. So we're responsible for the whole county, but, you know, if there's a lot of people in downtown Ann Arbor, we get a lot of people in downtown Ann Arbor. So a little bit about the mental health system. I don't know if that answered your question.
Thank you.
Can I take myself off the panel now?
I think there are questions for you. Patricia?
I did not set this up.
Poor guy. Stuck now. So, Dr. Florence, if somebody receives services through CSTS, how do you integrate physical health into that? I know you said there's a core set of services with social worker, nurse, psychiatrist, and all that. So do you refer people to have physicals, let's say, to test for metabolic syndrome, or how is that handled?
Great question. So it's a both and. You know, if you look nationally in the country at people served in community mental health systems, you'll see a population of people who are very medically sick, as well as having significant behavioral health problems. And nationally, data would suggest that if you have a serious mental illness, you are less likely to access medical care. You are less likely to be able to have an opportunity, for whatever reason, to adhere to that care if you are getting that care. And sadly, people die much younger than they should in the system. So, you know, with Dr. Ryan at Packard and some other clinics locally, one of the things we tried was to see if we could be in those clinics. And then if some people from our system who are complex medically and psychiatrically, but a point in their recovery where they could move their care to a primary care clinic with on-site behavioral health services, that might be the way to go. And for some people it was, but for a lot of people it wasn't. So the next thing that we, you know, have been working on, and we have the good fortune of landing a pretty big federal grant for this, was to bring medical services into the mental health center. So we have a grant from a group called SAMHSA, something called PBHCI, Primary Behavioral Health Care Initiative, that allows us to have on-site physical medicine nurse practitioner, on-site medical disease management nurses. We call them nursing nurses because we hire them out of med-surg instead of out of psychiatry, to really help people manage diabetes, hypertension, cholesterol issues, whatever other kind of medical things come along for the ride. So for us, it's been great because it actually was an opportunity for more resource, an opportunity for us to develop a data set so we know all of the physical health conditions of our mental health consumers. And then we can try to splice and dice things to try to, we're not an insurance company, but we tier in that regard, because we tier based on medical severity, so that we can also try to look at who must we go find who might have medical conditions. So at our place, if you can't get to see Dr. Zazoff or Dr. Ryan, or might not be associated with their clinic, or for whatever reason feel more comfortable coming to our shop, then we'll try to do that right on site. So you can get physical exams, medical diagnoses, medical management. But the big thing, in addition to that, if you look at, what causes increase in morbidity and mortality, there's a group in Wisconsin that's done a nice job of laying out kind of by county in the country, what's the health of the county. And if you look at some of this morbidity and mortality data, about 20% of the problem that leads to an increase in mortality and morbidity is lack of access to medical services or quality medical services. So about 20%. About 30% is health risk behaviors. None of us manages our own lives, our own health optimally, So if you can help someone to modify health risk issues, stop smoking, stop drinking. If you have diabetes, don't go to the 7-Eleven and get the Coke Big Gulp. You need another alternative, right? So we're really big fans of patient activation, which is a medical side term, using on the mental health side something we call motivational interviewing, how to help someone set a discrepancy up between where they are and where they want to be, and get them to tell you what the steps are to get to where they want to be. Kind of a different way of talking about things to try to activate people. So we're trying to roll motivational enhancement with activation to work on health risk behaviors. It's about 30% of the problem. Right? But then there's still about 40% of the problem that is issues related to poverty. Income, housing, I can't come to the appointment because I don't have childcare, transportation, whatever it happens to be. So from our perspective, that's 40% of the issue, right? That's social services. So we need an organized system of care that can bring medical services and social services together in one entity. Kind of like what we would call a safety net, not clinic necessarily, but a safety net service array that can be linked and coordinated seamlessly. So we would say the medical model is absolutely necessary, but not sufficient for optimal health. then we kind of got to bring them all together. So that's why we, use our band of social workers to try to go after that 40%. And from my perspective, income, housing, and social relatedness are treatments, just the way the Risperdal that I use or the cognitive behavioral therapy that Danielle might use. So that's what we're kind of up to right now. And coming to Washtenaw County is something the state is gonna roll out Medicaid health homes and have a few communities in the state try to be what on the medical side is called the patient-centered medical home. Kind of the converse is, if where you are comfortable is the mental health center, how can you try to get everything that you need, including from the medical side, but the quarterbacks are in the mental health side. So come July, we're going to actually be a pilot health home site in Washtenaw County,
It's
which
all
we're really
good
excited
news.
about.
It's
too.
really great, yeah.
Your band of social workers you referred to, how many do you have and what's the caseload?
Caseloads are high, there's no shortage of business. And I'd be lying if I could tell you an exact number. I don't know. We have, I don't know, probably a couple hundred employees covering the whole county, serving people in different program lines. Youth, adults with serious mental illness, adults with developmental disabilities. So a fair number of social workers. I mean, the backbone of community mental health is case management, and that's what we rely on our social workers for, really, to kind of help to, when a consumer, patient, client, depending on your persuasion, needs something and calls the play, that social worker, case manager is the quarterback and runs the play. They might not be able to do it all themselves, but they need to know who else needs to be involved with the team, at least in that moment, to kind of run the play. So a lot of people, variety of places in the county, but there is a lot to do. And when it comes to psychiatry, we've got psychiatrists as well. It's no easier to get into a psychiatrist than it is to get into the primary care doc that you want to see. And if you're on my caseload and I'm not available for whatever reason, if there's a crisis or that we have to prioritize or whatever, then it might be one of my colleagues that you see too. So we run into that same kind of issue that came up earlier today.
Okay. We'll give you one more.
Okay, maybe one more,
Yeah,
okay.
okay.
In regards to your staff, nurse that's on staff, if a person is given a prescription, let's say, and they overdose on it, let's say it's trazodone or amitriptyline, is it automatic that they'll stop that? Will they stop the prescription automatically because they overdose or have an allergy towards it? Or would just keep going? CVS calls it, your prescription is ready after they overdose.
So, I'll speak in generalities because I don't know any specifics about any specific case, and even if I did, I wouldn't talk about a specific case without a release of information, which is the other thing we're talking about. So, I mean, you want to use medicines that are effective, tolerable, safe, easy to use, and accessible, which often means affordable, right? So there's kind of the 5 dimensions that we think about when prescribing anything. And if someone is prescribed a medicine that could be lethal, an overdose, and someone is acutely suicidal, then we probably don't want to use that, or we need to change the intervention. And it might be that we're going to hang on to that medicine and see you every day. It might be that you're going to end up on our assertive community treatment team, which means we can see you in the community twice a day and do eyes-on medicines twice a day, 5 days a week at least, and once on the weekend. It might mean that we got to change the plan. So it all depends on the scenario. But optimally, you wouldn't want to stay on something that would be considered unsafe, and if it was someone overdosed on, it might be considered unsafe.
Yes.
I had a question about having more nursing nurses at CSTS. So how close are you, or maybe this has to do with the home, either the healthcare home concept, to actually having primary care physicians, so that, I assume that these nurses they can't write prescriptions to change or manipulate anything like blood pressure or diabetes.
Oh,
So it really just sort of So that's my question.
No, great question, yeah. So RNs, registered nurses, aren't gonna write prescriptions. They could, take a verbal order from a physician for something. Nurse practitioners can receive delegated prescriptive authority from physicians to, in effect, become prescribers. So we have the good fortune of having a medical nurse practitioner on site who's supervised by a medical physician who's not a psychiatrist for those kinds of issues.
So you have that on site?
We have that on site.
Okay, so how often is there actually a physician there? It's a physician.
Right. So there are absolutely times where what we can do on the medical side when it comes to prescribing is beyond the scope of what we should be managing on our own. As Dr. Ryan mentioned earlier, you got to know your limits. It's one of the most important things. So, our nurse practitioner, under the guidance of a physician, will initiate certain medicines based on her knowledge base, be able to go to a certain level of intervention. But it's really important that for many people, we're coordinating either with a comprehensive primary care clinic or other specialists too, just so that we can kind of round that out.
So then the challenge is everybody communicating back.
It is. That's the challenge is everyone communicating back. So one of the neat things that just got, I think it did, might know better than me. I think the universal consent form just went through the House, I think. It was ready for the
My era is
government to sign.
HIPAA. I don't know about the
But,
new one.
One of the things that we're really interested in is how can you create so there, we all want to be able to talk as much as we possibly can. The limitations are time, and you might not have a release of information that allows you to do it. And when it comes to behavioral health information, there are extra intense safety precautions around keeping information confidential. There's specific rules in HIPAA and other places. So the bar is set pretty high. And that is to protect vulnerable people from inappropriate sharing of information. The downside of it is that you can't share information a lot of times. But one of the things we're big fans of is figuring out ways for everyone, at least on the safety net provider side, to be able to actually at least use the same consent form. So that if Dr. Ryan signs a form and says it's okay to talk to me, I don't have to have you sign my form too, so that we can just have his form count, back-to-back conversation. Right now, he might have to fax it to me. But the other thing that's coming with that are also health information exchanges. So electronic health records are not very good at talking to other electronic health records, but you can create virtual portals that allow information from one record to flow into another record. They're called health information exchanges. So we're involved with some projects to try to operationalize that in Washington County. So we've got some things that are live right now. So right now in my clinic, if someone is seeing a university lab, gets a lab draw today, and the result comes back today, the result from that lab that's going into the university system is being pushed into this portal, the Health Information Exchange, and it's showing up in my chart the same day. It's fantastic. I looked someone up a couple of weeks ago because I heard she was in the hospital, and lo and behold, in my chart are all of her labs from the day I was looking at. They were drawn that same day. That's fantastic. We can do that with other things too. If you could have multiple records that can function as one record, you can get closer to that uniform, organized system of care where I'm not going to order something because I can't get the result, but it was already done, I just can't get the result. Better for the patient, better for the bottom line, better for everything if we can actually function as one. So we're really excited about those health information exchanges, and we're big proponents and pushing that, and we're using them right now, getting physical health information. The person who created our record, in conjunction with now many others, has actually created a consent form, an electronic consent, that will allow us to also share mental health information with the Health Information Exchange. It hasn't happened yet, but it's teed up and ready to go, which is fantastic, as long as all of the safety precautions and protections remain in place, right? So everyone's looking at it, but we're hoping that it's not just us drawing down physical health stuff, but it's an opportunity to also share behavioral health things too. So it's, all this stuff is kind of in its infancy in many ways. Some places are further ahead than others. I do think it's the way of the future. I do think as we try to work on what do we need to do now, optimally we would do things now that will be consistent with where we want to go in the future. Do things now that work, that don't take you offline from the big prize. Organized system of care for all, medical services, social services linked, do what you need to do the right thing, serve, right? That's where we all want to get. And we're not there, but that's where we need to go, I think.
Let me ask a question. You deal with very complicated cases. That's the nature of what you do. I suspect Dr. Ryan sees similar kinds of cases, different GPs differently. How do we teach primary care physicians to unpack this situation? How to figure out, well, it could be we've got a dependency issue, a drug dependency issue, or maybe we've got this, or maybe we've got that. Do we train doctors how to do that in medical school? Do you folks or any other folks serve as a resource to help primary care doctors deal with these complicated cases when they show? Like I said, I suspect you get those kinds of cases, but there may be some primary care doctors that would be a little flummoxed by that.
Yeah.
So in family medicine, when you can speak for, part of the requirement be a training in residency is behavior health. And every program has at least a PhD, if not a MD psychiatrist, and the program. We do too. And that's integrated into the 3 years. We're the only primary care specialty that does that.
So you feel like we're on it?
Yes. I think, like you said, you have to know your limit. I really think that's where it comes down. You have to say, my limit, it may be different than his, which may be different than somebody else's, and everybody has a different limit. But I think most of us feel comfortable with the initial evaluation, the assessment, and then saying, this is my limit, or no, I can take care of this.
Yeah, so you feel like you can sort through, is this an addiction issue? Is this a mental health issue? Is this some sort of behavioral issue?
Yeah, the behavior is the hardest one. But I think that the biggest issue, though, is the access and the stuff we've been talking about tonight.
So a lot of that, to me, at our program at Packard, we dealt with people who couldn't quite get into CSTS, but were sicker than I saw in Dexter. So it was like a moderately severe group. And we went through a really pretty intentional process to try to really train the primary care people to a little deeper level over time than you would typically see. I use the term suburban family practice or standard family practice because that's who was coming in our door. So, it takes some time, and people start at different places and move along, and then some people are just better at it, right? So Tim and our MSW actually, we're a small enough group, they actually created sort of an educational program for each of us that was not didactic, right? It was adult learning and all sorts of creative things about how you teach adults who are well trained to go deeper in an area than their standard training is. When you do that with physicians, you have to have good backup, right? Because if you're doing things a little bit differently, you have to make sure you have specialty backup while you go there. So that was actually one of the more fascinating processes. This has been just a great program for me, and that was one of the real fun parts, is really getting a group that has more training and does things. We assume that we do things now that, you know, a decade ago we would have, what? You want me to do what?
Yeah, if I can just piggyback on that. So it's also been one of the most challenging and rewarding things for me is being a psychiatrist officially for a half a day a week in a clinic that serves 9,000 people across 2 sites, targeting the uninsured and the underinsured, right? So I ran the numbers once, and if I personally evaluated everyone in the Packard practice who had a behavioral health condition and saw them once, just once, I think we decided it would take, based on my time allocation, 23.5 years or something. So which was great, because those are, but if you, when you say that to the primary care team, like, well, that model's not gonna work, what else can we do, right? So my job really at Packard is to be the backup person for the primary care docs and someone who can help primary care providers to expand their breadth of knowledge about behavioral health conditions and depth of toolbox to use for specific ones, so that in fact primary care providers can become psychiatry extenders too. Without that, they're already prescribing the vast majority of antidepressants. But you know, at Ray's shop, you know, there are a whole bunch of people who need other forms of psychiatric medication too, and we needed to get to them as well.
But do you feel like across the country, in training primary care physicians, that they're learning these skills? I mean,
I think we have a long way to go. I actually think there are great opportunities for us to think about what we're talking about today, integrated care, and how to develop training modules that we think could work, that can be evaluated, and if they do work, there can be a spread strategy to disseminate them. You know? So for many years, and Dr. Zazov doesn't even know this, I worked at Ipsy Family Medicine as the psychiatrist there for a little while, which was great because every family medicine resident has to be a psychiatrist for a while to graduate. I love that model. They have to tolerate me in their clinic doing this stuff. Which was great, which also meant I could take them to my shop too, and I would take the Ipsy Family Medicine residents to our crisis residential services house, where people who need, you know, really 24-hour intervention can stay in the community, but still hopefully get what they need. It was a great opportunity, you know, for me, but also I hoped for trainees to learn more about the mental health side of things. I think we need to do more of that. I think there might be opportunities for us, given the movements, the winds that are pushing us all towards integrated care, to even do more than we're doing now in training programs and across, you know, a variety of disciplines that provide primary care kind of function.
Phil, you're in the medical school. Do you see this changing in your training of doctors?
Like, this year, next year we're totally changing the curriculum. Totally. Not bad until they get part of it. But I don't know. I'm not doing it. But I know they're totally changing. Because the first 3 years are going to be 2 years, and they're going to be making all these tracks. It's like a tree with branches and...
This is not going to be like a new model of a car that you don't want to buy the first few that come off.
I don't know enough about it. Yeah.
Okay. All right. We've got time for one more question.
Let me state an observation that I'm confused about, because I'm not very familiar with this. But I hear in this conversation what appears to be terminology that seems to contradict. I hear the term behavioral health, and I hear the term mental health. And they would seem to be antithesis to integrated care, because they don't seem to project the same core values and shared understanding that would support alignment and integration. Am I mishearing something?
Anybody want a piece of that?
I'll take it. I absolutely agree with you. Language matters. language matters, and how things are framed matters for a whole complex variety of reasons. So on the, I'm a psychiatrist, I come from the mental health side. Right? When we say behavioral health, for us it's also code for, in addition to a mental health condition, it is the expectation, not the exception, that there is also a substance use condition. There might not be, but for me, behavioral health incorporates mental health conditions, developmental disabilities, and substance use disorders, which hasn't really been part of the panel today, but that's another big issue. So when I say behavioral health, I'm thinking all the stuff that we do on the psychiatry side, plus the substance abuse related treatment providers who are also behavioral health clinicians. So on the primary care side, that's kind of different terminology. Dr. Ryan mentioned the kind of the cultural divide between the mental health system and the medical world, and how we haven't gotten into a lot of detail, but ways to try to bridge it. And this is one of those things, and I appreciate you pointing it out, that we use different language, and that's one of the issues.
Well, can I tell a story about that? So I was in Santa Fe one day. I was at a conference. It was the National Society of Mental Health Administrators or something like that. And I was one of 5 primary care docs trying to convince these people that integrated healthcare was a good idea. So we all trooped up there. We each had about 5 minutes, told a couple stories. Then a consumer got up. First thing he said is, I've been listening to these people for a half hour, and I have one question. What about recovery? And the primary care docs on stage, I kid you not, we looked at each other, we said, what's recovery? True story, true story. This was 7 or 8 years ago, yeah. And we were there pitching this. What about recovery? I kid you not, we all looked at one another and said, what's recovery?
There's so many different examples of how there are language differences. My treatment plan in Dr. Ryan's shop, in my mental health shop, is called an individual plan of service, an IPOS, right? So it's the same thing. It's a different language, and that's part of the gap that we have to bridge.
Yeah, and that's going to keep that divide.
Yeah, that does.
This has been a fabulous panel, and thank you so much, Lynn, for the moderation and the questions. And